Hello, everyone. I'm here with Anita, who we've just been talking about. We met when I was
6 months old.
6 months old, and you were
18,
cool and
19.
and you would take me into
University, because we had to get paediatric clients, so kids, to learn how to be an OT, and we would take you and
here
do
we are.
splinting and all sorts of cool stuff.
And now we're talking about sex in my bed.
Yeah.
27 years later.
Love it.
So this is very cool. All right. So, what do you do?
I'm an occupational therapist, and I love being an occupational therapist. And what I do, some people know what OTs do, but basically what we do is we look at the things that people want, need, and have to do, and how does disability or disease stop them from doing it, and how do we get them to do that again. So it's a really practical profession that just goes, right, so you've got MS or you've got chronic pain or you've had a stroke, how do we get you back to doing the things you want, need and have to do? So it's a really privileged profession. So I've been doing it, you've outed me how old I am really. I've been doing it for 23 years, oh my Lord, and then trained for 4 years before that. So, you know.
And you've got a particular, you obviously do 101 things in
Yes.
life.
So I work at a hospital doing stroke rehab, but basically for the last, ever since I trained, but for the last sort of 10 years, I've been running more education business around sexuality and intimacy in OT. So part of that is working with a sexual health nurse, and we train other health professionals how to talk about sex and intimacy, and the other part of it is actually just working with one-on-one clients, mostly through NDIS, about chatting about what are the barriers of intimacy and sexuality, and how do we, if they want to get back to sex or redefine what sex is for them in their disability, we do a lot of work around that. So, often get called for when there's some sort of problem, but really keen to be looking at pleasure and, joy really associated with that.
So for people who, I guess more like traditionally able people who might not be thinking about what these barriers are, like I certainly hadn't thought, like for a classic example, people go like, well, I wonder how someone in a wheelchair has sex. Yeah. And that's kind of like the able thought, like it's like, well, that's what disability looks like. So what kind of things are you dealing with? What's the spectrum of, in terms of looking at people with disabilities?
What we work with?
Yeah, what are you working with?
Oh, so much. And look, I think that there's some great disability advocates out there which will talk about this directly, and I'm really always for the nothing about me without me. Yeah. But I work on, I suppose, a whole spectrum from people, a lot of my referrals are for people with intellectual disabilities or autism that maybe have got into trouble with the law, and I'm more going in and just finding out what their sexual knowledge is, which is usually pretty crap, because most people who are born with a disability are often considered asexual and you don't need sex ed, whereas get on a bandwagon that actually paediatric therapists and doctors and everyone needs to actually be making sure that we're educating kids with disabilities about body autonomy and what their body does do, and seeing them as future sexual beings, because education is power. There's a lot more, unfortunately, sexual assault for kids with disabilities, but also there's a lot more concepts around people not having knowledge about consent, education and all of that as they're growing up. So I do a little bit of that stuff, but probably most of my stuff is people who have developed illness or disability later in life. So doing a lot of stuff with people who might have MS and how their nervous system has changed, therefore how their experience of sex. So it can be, from a really OT point of view, it's positioning. So if I've got a bad back or I have really chronic pain in my hands, then how do I set up a sexual encounter so it doesn't hurt? And we often do the whole what's the balancing act as such, in terms of still having enjoyable sex, which can release really good chemicals and endorphins, which help with pain management, to, but then how do I how do I get there? You know,
how do I logistically actually perform?
Yeah, how do I logistically perform? And I still remember I worked with one young woman who actually had became brain injured from a sexual assault, but she actually had a brain injury, which meant that her legs had a lot of spasticity, so they couldn't get spread as such. So I do a lot of work with educating and empowering people about knowledge of the sexual response system, and that particularly for women, that once a woman can orgasm, then their body releases and relaxes, and so they can get into different positions. So people who are born with clitorises do have the special ability to possibly have multiple orgasms. It doesn't always happen like that, but knowing the sexual response system, so lots of people with cerebral palsy might use sex as a way to control their tone. So I talk to physios and say, look, you might have had a great physio session the day before and the person's come in the next day and they're walking really well, but it may have nothing to do with your physio session. It might be just that they had an orgasm the night before and their body drops out. So particularly for this woman, we worked that her partner would give her oral sex because they could access her vulva area, even though her legs were really tight. And then once she orgasmed, she could relax and spread her legs and then could engage in partnered sex. So trying to actually teach people how the body works from a physiological and an anatomical perspective, then that actually helps us then problem solve. Everyone's different and all that things, but as health professionals, we're not taught that in universities. We're still not taught that. Like I will walk into a health professional education session and, people have zero knowledge. We know how babies grow in the uterus and all of that sort of stuff and really in detail, but we don't know just how our body responds to sex or, just sexual stimulation and the sexual response system. So knowledge is power, I think. So a lot of my work is also, so it might be practical stuff of that, or it might be referring on to a sexual health nurse and go, look at the medication you're on, no wonder they're all nerve blockers. Like, it's going to be really hard to, get to a response to that, or it might be looking at just how does that illness or disability, has it affected, so someone with diabetes, it affects the small blood vessels, so, for fingers and brain and penis as well. So, or if cardiovascular disease, they often say that all the doctors should know that, but basically if you have a penis and it's not working, you have erectile dysfunction, the first thing you do is you go to the doctors, because it's like the canary in the mind, that if there's small blood vessels have got built up of calcifications, then you might get built up of calcifications around your heart, and that's how it's a precursor for a heart attack. Wow. So you need to be aware. You did not know that. Yes. So it's one of those.
The doctors did not.
Yeah, no, I'm sure there's not. And I think that's one of the things that I often say to the health professionals and to people is, how often has your doctor had the conversation about sex with you? Like I know my GP has never, though I think I brought it up. So this is what I do, blah, blah, blah. But there's not, unless the research all says that unless health professionals go, I don't want to go there because I don't think I'm trained and I don't have the skills or I'm not appropriate. Yeah. And clients go, so all the research is very much the things that clients or people with disabilities or diseases want to know this information, but also feel like, well, maybe I'll be seen as weird or as sexually inappropriate, or if I do ask the question. So, but it's a breadth of things. I have a very good friend who's an OT who has cancer herself, and going through and specialises in sexuality and sex, and her cancer treatment is like no conversations around that, and dry vaginas, and how safe is it to have sex when you're having chemo and all of that sort of stuff. So she's got I can put you onto her website as well.
Definitely send us the link and I'll pop it in this bio. There was a particular thing I wanted to ask about in terms of, this is kind of where I started thinking about it, I guess. So obviously I've been in pain, and I've been very lucky in this experience. Over 80% of people who have endo have painful penetrative sex. Yeah. And I've been pretty lucky to navigate that and had a very supportive partner in that space. But I kind of didn't realize there's two things I want to ask you about. The psychological impact and the trauma that is never spoken about. No doctor has ever sat me down and said there may be like 100 random people between your legs who are going to invite, all these students in to just jump on in there, and that may cause you stress and trauma and may kind of rejig how you see this intimate space. And also the fact that in order to counteract my pain, I was given nerve blockers, which then inhibits the ability
to get an orgasm, or to actually get your clitoris erect. So the clitoris works like a penis, it gets erect.
So for me, that was a really big juggle, and I've been very lucky to be in the percent where that hasn't actually impacted me, but that was something I sat with heavily.
Oh my God, I'm going to take this and it's going to kill my sex life.
Yeah, and it's like, okay,
sexual suicide.
It's pain, not even just like sex life, but pleasure is something that's so important in everyone's life, but especially if you sit in a space of pain, that's that one thing in your body that you have control of and you can enjoy, and
actually makes it better.
Yeah.
Like sex, if sex was a drug, a doctor would give it out all the time.
All the time.
Like,
yeah, so it's like, I wanted to talk to you about the two elements. So the psychological impact as well as...
It's huge.
Yeah, let's just focus on the psychological things, because we're going to do 100 episodes. You're my hero.
I know. I remember we did some training around cancer, and particularly cancers, around the female parts. Yeah. And I remember watching a video. It was talking about it was like a war zone down there, and that people are not giving. You're not having autonomy over your body, and there's no consent, that people are just coming in and, hey, have a look at this, and hey, have a look at that. And that's and often I think for young people it's their first penetrative concept is, being, particularly with endo, like it's pretty...
what I worry about, 15-year-old
women. And I think because we've had a little bit of these conversations, and I've had a friend whose daughter is having lots of painful periods, and I'm like, well, just be aware, flag it, because it is really hard. And I think the psychological aspect of that needs to be talked about, but PTSD, even so I do a little bit of work with people, and it's interesting, it's the health professionals I provide education to will often contact me afterwards and said, look, I've been involved in a sexual assault, I want to get back to healthy sexual relationships, but I'm finding it really hard, or I have vaginismus, which is that, closing up because of psychological trauma. And as an OT, I'm not an expert in that. Like, I have really good referral on options, and I definitely would refer on to a sexologist, or, the Monash Clinic or the Austin Clinic for that, because it's not my area of expertise. But again, we need to understand the impact of how trauma works, and trauma, you can have trauma from actually just the medical trauma, which is, I think there needs to be heaps more research around that, and again, just education. So a lot of it is about that ability to consent. So if someone asks questions, do you mind if I look down at your vulva, you have an option of saying yes or no, whereas I think even they could go through the concept of asking, but you don't really have a choice in that process. So educating health professionals, if people say no, then today that's a no, and that's it. And it might be that you need to do examinations another way or another time, or I just can't do that now, thank you very much. And I don't think people are given that permission. So again, we talk about what's in the media at the moment is consent. For sex is a big thing, but consent for medical trauma is a big thing too. And knowing that that we should be giving people that right, and just going, well, I'm going to have to come back to maybe we'll try that next time, or in a different environment, or are we private enough? Yeah. We're not in a big room, or what can I do, Fee, to make this a better experience for you? And then it's working with psychologists, I suppose, afterwards on how do you actually engage that. And I think the biggest thing for what I talk with my clients about is it's communication. Yeah. So particularly with a partner, we often talk about how do you keep the pilot light on? Like, it's the old gas, you live in an old house, so having the old gas pilot light on is that when people are going through trauma, how do you keep the connection with you? If you have a partner, how do you keep the connection? And that might be holding hands. It might have nothing to do with what you think is a sexual script.
Yeah.
But how do you keep that pilot on, and how do you keep on talking to your partner in a really open, and I think you've probably been able to navigate a lot of that stuff because you're an open, and you will talk to your partner about it, but lots of people don't have those words for sex.
Yeah. Because they don't know them.
They don't know them.
We
have taught them. And I worked with one lady who was in her 50s who'd had a brain tumour, and I'd been sent in on the hospital just to do a quick conversation with her, like initial interview. And I always talk about sex. I said, any issues around sex or sexuality? And she just looked at me and just went, yeah. And we talked about that she'd had cancer for 3 years and had a huge brain tumour, so nothing to do with the nether regions, but your brain is your biggest sex organ. No one had talked to her about it. Her partner thought he was going to crush her, and so he didn't want to touch, so you withdraw from touch. She withdrew from touch. Yeah. No one talked about it, and she ends up 3 years later and they haven't had sex for ages, and she really missed it. So because she goes, I've never talked about sex. We've always just had sex. We don't talk about sex.
Yeah, that is an interesting one, actually. Another thing that maybe we'll do an entire episode on at some point. But I definitely know in the endo world, because penetrative sex or any kind of sex can cause pain, that partners then begin to associate, like, I'm adding to your pain. I'm going to withdraw from that because I'm going to add to this.
Can
I
you
don't
imagine
how
you don't? It's a minefield.
Yeah, and I think I've been thinking a lot about medical trauma and nerve blockers and all these things in the context of what I've been going through, and essentially, it comes down to education. But it'd be so great if doctors just at the start of the process said, there's going to be so many randoms that are going to just go up in you, and that's going to impact you in so many different ways.
Shouldn't be so many randoms.
But, like that they give you kind of a heads up that this might go on for a long time,
I think it's also giving the heads up to say, you have permission to tell them to fuck off.
Yeah.
Am I allowed to swear on this?
Well, we've all been swearing.
Yeah, okay, good.
We'll beep it out.
We'll beep it out, that's good. But you need to give people permission to have control over their bodies.
Yeah.
And medical trauma doesn't,
it doesn't allow for that. I feel like we have about 600 episodes together, so hopefully we're working together.
Yeah, now. We are working together now.
So we're going to keep doing this. But thank you for explaining the beginnings of what you do. And I think it would be great to just have a segment with you, because I love talking about sex with you. And how weird that you would end up talking to the 6-month-old about sex.
Yes, I love it.
Here we are. There you go, Mum and Dad. Look at my mentor now.
You can talk to my kids.
Damn it, why did I introduce them? Sorry.
It's all good.
Now I'll carry it on with your girls.
You can talk to my girls, because they don't want to talk to me about sex.
Absolutely.
They're pretty embarrassed about what I do, which is rightfully so. Yeah. I did say that I would put clitoris on the car, and they didn't like that. That's another whole episode.
Yeah. Do you want to quickly tell the story about what Tamika said when...
Or what Matilda said when I got my
Matilda,
first...
Yeah. Can you...
Oh, yeah. I had ordered over the internet just the basic clitoris, 3D printed as such, and Adrian, my partner, had come home earlier than expected, and it was a work function at our house, and he'd bought a carload of builders with him. Yeah. And this package had just arrived from Germany, and I was pretty excited because my clitoris had arrived. And Matilda, who was at that stage probably 6 or so, ran up to the dad. Daddy, Mummy's clitoris has arrived from Germany.
Just all these
and all these builders was like, what the hell have I walked into? And pretty much that's our family life.
That's your family.
Yes.
And I love it. And the kids love it.
They will eventually love it. Maybe not now.
No, they'll come to me and they'll think you're cool later. That's what happened.
Yeah.
Thank you so much for talking to us.
Pleasure.
And we're going to keep talking about all these things probably forever.
Yeah. Yeah.
And then I'll talk to your kids and
Yeah, that's
we'll
the
get
deal.
Mum in here and
It's the deal.
4 generations.